So you had your charge regarding disruptions, comparing and contrasting some examples across the professions, what we can learn from those, and then what suggestions you may have come up with as a group, and certainly which of these are most challenging. Who would like to lead off the discussion? Yes, table 4.
Hi, Kathy McGuinn from the American Association of the Colleges of Nursing. And of course, we started from the very beginning and had to challenge everything and said, why are we using the term disruption? It seemed like if we're really moving to patient-centered care and the patient's at the center of decision-making with us, we would know them well enough that they wouldn't be disrupting. But then we all gave specific examples how there is so much disruption in all the different care settings. So we questioned that. I think Susan had a good point about someone showing up with a headache at 3 a.m. in the morning in the ER, and the doctor is saying, you know, this is disruptive, and why would somebody do that? But then she made the point that, well, before anybody shows up in the ER, they've talked to 3 different people. And so you really have to get to the root cause of why they're coming and what's really going on. And then you find out someone died of meningitis recently in their family and all these good things. So what we sometimes look as disruption is, I think we have to reframe it and kind of look at it like we need to know our patients and what they're going through.
I appreciate that greatly. In fact, the reason I used that word, look at your assignments for tomorrow, when you are going to be dealing with disruptions, and I thought, I'm going to use that word and see what it triggers for you guys, because you are going to be looking at other disruptions, and I think we often flippantly see patients and families as disrupting our smooth flow. They were supposed to be here at 10 o'clock so I could teach them. Where are they? Thank you for that.
Yes, 7.
Well, we weren't quite sure what we were doing. But we did start out by identifying patient circumstances where the patient's interests were disrupted by other members of the family. For example, somebody's dying in oncology and the son comes in who hasn't been there or hasn't been with the parent for a long time and suddenly wants everything done when the rest of the group and the patient want to be at home with hospice. And we talked about how that was disruptive in many ways. You know, how do you manage that in a clinic when you don't have time to deal with this son's need, which is to bridge that gap? It isn't about the patient, it's about his need. But he's disrupting care for the mother who wants their children to be happy and to heal this. And so that was one example. And the other example that we came up with was being at home and recovery, you know, and how independent an elderly couple might want to be might differ from what the family thinks they should be. And how do you manage that? So being in the context of education, we asked, how do we teach about that? How do we help students to understand that kind of communication? And we didn't get very far, but we thought that simulated patients are by far the way to go, because it becomes very clear what the evidence base is for the choices to be made. But it's not clear to students how you communicate and deal with those messy sort of situations.
Thank you, and I'm going to share the microphone here with McGill because he's also palliative care. My other thought there is, what happens also when you're in the clinical setting and the clinician that's leading the team at that point in time is adding to that disruptiveness, because they maybe didn't learn the lesson your students have. Gil.
I would only add to that, I am thinking as you're speaking, Joanne, that of our United States medical licensing exam, and we have a clinical skills portion of this. And in none of those scenarios yet have we actually had more than one person as the standardized patient/family member. And I've been lobbying for that because this is a competency that I think we typically, and Kenita's nodding her head, we don't think about. And so I've heard already I'm hearing things related to the assumptions we make as providers when patients present. And I'm also thinking in the back of mind, when my doctor doesn't look like me, how does that change my perception? And then how does that change how I deliver care? And then, of course, family disruptions, how we manage that, and how we teach about those things. And all of these things maybe play into our wellness as providers too, I would imagine. So let's hear from someone else. Yes.
So if I can summarize for us, in addition to everything that's been said about families, with which we completely agree, we talked about the complexity of teaching how to sort out patient requests from best practices, because it can really work both ways. So Caswell gave an example in West Virginia where young women want to have all their teeth pulled before they get married, and this presents an ethical dilemma for dentists, but they do it. And so, this would be a whole course in medical anthropology to talk about it. But when do you override someone? So if there's a harmful practice, like the use of a lead powder and diarrheal disease in children on the U.S.-Mexico border, Azarcon, you don't want kids ingesting lead, so you have to fight with that one. But the other example from medical anthropology is Navajo congenital hip disease, where if you have it, you have an awkward gait. You don't walk nicely, but you can ride a horse and you can sit around a fire. If you get the surgery for it, which Western biomedicine wants us to do, then you can't ride a horse and you can't sit around a fire, but you can walk nicely. So that's a case of where really you need to respect the culture and the patient. And I think the most complex thing is teaching healthcare providers how to sort that out. And the tried and true case studies and case conferences and interprofessional case conferences, and also after students or practitioners have been out in the field, getting together to talk about experiences and cases and how do we make the best decisions. So there's this fine line between respect and then best practices, but best practices keep changing, and that adds to the complexity. Anybody, did I summarize it? Okay.
Thank you for bringing up another point, and a very important point. I'm going to push you one step further on best practices. We base those decisions on research, correct? How many patients and family members were on the research team?
Well, and I think that's a really key question. I'm a medical anthropologist. That's a key question. And even going back 20, 25 years at UCLA, we began involving patients and communities. It's not just patients, it's communities. But you're absolutely right. And Miguel already talked about the issue of cultural diversity. People may not feel comfortable even talking about what they really want or believe to somebody who doesn't look like them or they think may not respect their ideas. So very, very complex.
The terminology in terms of involving patients, caregivers, and communities has been very interesting for me. Monday, we have a major steering committee meeting, and we've run into people for whom the community means their medical counterparts in their community. So the medical community in this town, whatever, all agree that this is how we should be treating these people, or it includes all of the health providers, but community doesn't necessarily include the lay people that we are really pushing to be involved. So thank you for another twist.
We'll go with table 3, and then we'll go back to 2.
So I'm going to represent our table and hopefully do it to the best of what everyone said. We looked at disruption in a slightly different way. We thought about increased productivity as the disruptor to decreasing the relationships that you can have with patients and their family. And not necessarily did we talk about the differences in how health professionals hear, but what patients decide to share with certain health professionals can change the whole story. So you used a great story about the nurse getting all this information from the patient. By the time the doctor walked in and the patient was asked, "How are you doing?" Patient said, "I'm doing great," because it had already been all shared with the nurse. But having each health professional have that lens of the amount of time that they get to spend with the patient completely changes the scenario. And then when we talked about the aspects of family dynamics that health professionals don't necessarily get true training in, how do you deal with some of those disruptive situations? And Kenita shared a really nice example, which led to the fact that many times there's underlying issues that cannot be recognized without that deeper understanding. And so how important experiential learning and role modeling would be for students.
The thing I want to pick up on your presentation is, in a group like this, I would often say, okay, think of your personal family. Does anyone not have a black sheep in your family? Will you please stand up so I can send my black sheep to you? You know, and we look down on families that don't get their act together. That's reality. Thank you.
Table 2.
Okay, so we have a little different scenario, and this actually really happened a week ago. At St. Louis University, we work with a local St. Louis Public Schools high school that has a school-based healthcare center, and they've had it for about 5 years. We've done some activities with them. They function around a nurse practitioner and behavioral health services, and we also have an athletic trainer in there and some dietetic interns that go down there. And their community sponsor pulled out at the very last minute, like last May. And they basically scrambled all summer. We've been working with them to try to find another organization to help reinstate the school-based healthcare center at the school. And we had a meeting last Tuesday where we brought all the community people. We brought the SLPS, we brought the principals, the people from the high school, we brought in the people from the healthcare provider. And we're thinking, okay, let's do this right, make it sustainable, we'll scale it up, we'll be ready to go, all those kind of stuff like that. And the principal just looked us in the eye and said, you know what, you can wait all you want on those other healthcare providers. Behavioral health, not having behavioral health here is killing us. They said because, and this is everybody was thinking of all these other healthcare providers, but they're like, because we've had this school-based healthcare center for so long and we had walk-in behavioral health for our students, we've totally restructured our discipline policy at our school. So these kids showed up for school on the first day of the fall thinking they could walk into Brandy's office and talk to her. And, so instead of using out-of-school suspensions, they were utilizing the behavioral health provider, all those, and they were keeping the kids in school. They weren't, because sometimes at a school like that, if they leave, you may not see them for another week. And so the thing is listening to the people at the school. We're sitting there obsessed about, okay, how are we going to be able to do immunizations and physicals and all those types of things like that. Hey, they're like, there's people in the community that can help us with that. We need this behavioral health. And listening to the principal was really eye-opening for us. So it really changed our urgency of the way we were acting and those kind of things like that. So that's our disruptive.
Thank you. I don't know that I can add anything of significance to that. So true. We think we know the problem and how to fix it, but not always.
Next, let's go to the folks that don't have a seat at the table. We'll give you a seat at the table now. I don't like the term gallery. That doesn't sound right.
I'm Adrienne White from Adrienne White Faines from the American Osteopathic Association. This little subgroup, we have about 3 of them over here, had a really good conversation that was very similar about the issues of family and patient and who's in control. But the other disruptor conversation that came up, which we haven't heard yet, is the disruptor of technology. And what do you do when the patient comes in and the patient, in the case that was given by Dr. Ogle, the example is in the emergency room, he had a patient where the family member had a monitoring system on the patient, and the family member called to tell him what was wrong with the patient. And his job was to uncover an unapproved device that the family member swore by and said, this is really what care is about. So I think the issue that we all could come up with examples about was what is the role of technology and how do we teach for people to understand how to begin to synthesize between these systems and what you've learned in terms of proper care.
Thank you for that and giving us another item to think about. Another version of that is the family that does all the research on the computer and they know exactly what treatment they want their loved one to have and everything that's involved, and they walk in with stacks and stacks of articles and say, have you read these? And this is what we want you to give us for dad or mom or whatever the situation is. And they really don't have the ability to sort through and interpret all of those things. You had a device that was not helpful and probably harmful that you had to deal with. And I think a similar type thing when they want a treatment that isn't proven, or in the process of collecting what they're on, they don't totally come clean with what else they're taking that may actually be causing challenges.
I would just make two quick comments. One about the role of technology. I was shocked that the electronic health record hadn't come up yet. We could spend days and days on that. And that role can be disruptive or it could be positive. That's a whole other thing. The other thing I'll say is on our licensing exam, I'll go back to this, is one of the things we started doing the past few years is we now put multiple choice items on the exam that use fake pharmaceutical ads as the media to which the examinee has to interpret. And there'll be a vignette of a patient comes in saying, I brought this from Good Housekeeping, I think I need this for my CHF, and then there'll be 3 questions related to it. So getting there. Let's go one more in the gallery, and then we'll go to 6.
Jerry Lamb, I'm from Arizona State, and our subgroup over here talked about a variety of topics, but one I don't think that's come up is the issues related to alignment between patient, family, and provider goals, incentives in the system, and performance metrics. So we were looking at outcomes like no-show rates or readmission rates, which are part of value-based purchasing, and they become disruptors, and they become, why don't you show up when social determinants may be more of an issue than not keeping your appointment. I don't have transportation, the clinic's not open at night, and so forth. And the performance metrics are pushing providers who have maybe, what did we say, 7 minutes for a visit in terms of where their priorities are. So it comes down to, is patient engagement helping me hit my value-based purchasing metrics, and does it really make my life easier?
I appreciate your input. As a personal patient, I really struggle with how well prepared I have to be when I go to see my provider, because I feel I have to choose from multiple health-related issues. What is it I want to discuss with him today? Because there is no way in his allotted time is he going to have time to address all of my issues. And especially if he takes the time to say, well, what do you think? Because I usually have an opinion. So.
Let's go to table 6.
So we concur with what other people are saying, particularly about the technology that you were bringing up over here. The other thing that came up yesterday, we're carrying over today, is just the culture of mistrust, where it used to be, the physician knew everything and was the leader of the team, and now with the culture, the climate, the community, and I live in D.C., so, there's lots of skepticism, and are you really telling me this? I'll just give you a small little example. My mother lives in a rural Midwest area, and five of her friends have been diagnosed with atrial fibrillation. So now she thinks something's up with atrial fib. Why is everybody getting this diagnosis? So there's skepticism right there, and it's probably factual, but she's 83 years old. So any additions to the group?
I think the other thing that you really see is the hierarchy within a family. When the parents used to run the family, that's no longer the situation. These younger family members come in and they have their own ideas, and they can make us rethink what's going on here. Besides, they fly out of town right away.
We have time for one more table. We'll go to table 5, and then we'll give Barbara the last word.
I wanted to comfort you and let you know that we did discuss the electronic health record as a disruptive innovation in healthcare. And the other thing that we discussed along with that was that while this transition to electronic documentation has brought with it its own challenges, so has specialization. And, we had a story that was shared where, one patient has multiple specialists, and of course, each specialist is doing their own thing, and you don't know until 6 weeks into your plan of care that because of one treatment plan, for oncology, that your fractured collarbone is not going to heal, et cetera. So we talked about that, but we talked about how we have in fact created a disjointed healthcare system by moving away from a consolidated kind of primary doctor, primary care approach to this highly specialized approach, and then added to that an electronic health record. So just wanted to let you know about that.
And if one of your providers isn't part of the correct system, their part of the record isn't in there.
So I want to thank the two of you for stimulating a lot of conversation. Every time I come here, I pick up nuggets. I'm writing a lot of nuggets, so just very, very stimulating.
Barbara, I have to apologize. My slides here show up beautifully. My apologies that they didn't show up there. I normally...
Yep.
We have a better angle here.
Okay.
Yeah.
Good.
So we're going to break for lunch. We have an hour, so continue the conversations over lunch and networking, and we'll reconvene at 1 o'clock. Thank you very much to the two of you. 12:58 to sit down at 1.